All right, good evening, everyone. Welcome, Dr. Kevin Boyd and Dr. Simon Wong. Welcome to tonight's special chit chat, fire chat with you guys. It's a nice Wednesday evening here in the US and Thursday afternoon in Melbourne, Australia, where Simon is. So welcome everyone for joining us tonight. We have a really interesting topic. I'm going to pass it over to Simon, who will formally introduce Kevin, and we'll get started. All right, thanks.
Welcome everyone, and welcome Dr. Kevin Boyd. For those of you who don't know him, he's board-certified pediatric specialist dentist in the Chicago area. Special interests include nutrition and dietetics, which he has a master's degree in. He teaches pediatric residents at the Laurie Children's Hospital and is also a consultant there with the sleep medicine service. He's a professor at the Department of Anthropology at the University of Arkansas and looking at guiding the PhD students into looking at archaeology and anthropology. Most recently, Kevin's interest has drawn two diametrically opposing specialties, children's medicine and dentistry and geriatric medicine and dentistry. So I thought it would be good to say hello to Kevin and maybe ask you, Kevin, a little bit about what the link is between geriatric medicine and early childhood dentistry.
Yeah, and when I first started to explore this, I thought this is crazy and people are going to think I'm nuts, and I am, but this is something that is very plausible if you approach it from the fact that aging begins at conception. We call it embryological to fetal growth and development, and then, birth, and the cells start dividing and differentiating, and, before you know it, you're an infant, and actually every geriatric citizen was at once a fetus. So it's just part of the cycle. Some of the problems that are commonly associated with old age don't really become symptomatic, and I've sort of singled out Alzheimer's disease. I was recently at a conference, and the speaker said, how many here are over 40 years old? Well, every hand went up. Said, okay, look at two people. And guess what? Those two people that you saw, of the three of you, two of you will either have Alzheimer's disease. It's not symptomatic at 40, but there's enough beta amyloid in your brain, not everybody at 40, but beta amyloid are the plaques that are produced, and they start early in life, but the immune system in a healthy, young, vital person, it sort of cleans it up, but it gradually accumulates, but it doesn't give symptoms of dementia. There's other things that have to happen, but you're either going to have Alzheimer's disease, maybe early, or you're going to be taking care of somebody who's already suffering dementia, that you love and care about, and you're going to be a caretaker. So we know this. It's inevitable that all these, and again, Simon knows I'm very focused on helping children not only sleep and breathe well at the earliest possible age, hopefully before the age of 6, all right, but also to achieve and maintain a healthy body weight. My background is in nutrition and dietetics, and I really like to reinforce every parent's desire to help, their children have a very good quality of life, and a very good length of life, lifespan. Well, what good is it if we're enhancing these kids' ability to live into their 90s, maybe 100, if they're all going to have some form of neurological problem, dementia, neurocognitive issues, that, by 80 years old? So wouldn't it be nice if we could help these kids live to be 90, 100, and help them avoid age-related dementia until they're maybe 95? Then they only got 5 bad years. I mean, that's how I look at it. We want to compress the morbidity of aging-related diseases. And that begins, now the geriatric literature is saying, well, most people at 80 who have dementia, that they had the antecedents to it in their mid-30s to mid-40s, but it just wasn't symptomatic. Well, if they had antecedents at mid-30s, mid-40s, guess what? This is a hypothesis that we're pursuing, that those antecedents to those antecedents, if I can use that term, probably began in early childhood. Now, there's something called ACEs, Adverse Childhood Experiences, and ACE score. It's 10 things that happen to little kids in early childhood. They're really awful things, terrible things, like child abuse, like growing up in Gaza or Ukraine right now. I mean, these little kids growing up in war zones, growing up in famines, these are awful things that have their mark on kids. And it comes back when they're, in their late adolescence, early to mid adulthood, to give them really awful, awful susceptibility to things like cancer and kidney problems. And, look it up, ACE, Adverse Childhood Experience. And look at it, what an ACE score is. Well, if an ACE score is above a certain number, it's very reliable that this child is going to really have age-related adult diseases earlier in life than when they're geriatric citizens. There's something called biological pace of aging, and this is something that was first proposed in Dunedin, New Zealand, in your backyard, Simon. They had, it's called the Dunedin Birth Cohort Study. It's 1,037 babies born in the same hospital in New Zealand, and they've been followed. There's over 1,000 of them still being followed, like 54 years later. Go figure. Okay. Well, one of the things they found was if a child does not demonstrate really excellent impulse control before the age of 12, think marshmallow test. If you haven't heard of the marshmallow test, Google it. Okay. It's all over the place. And it was an experiment, psychological experiment done in the 1970s, I believe, or 80s. It wasn't part of the Dunedin trial. There's other metrics that they use for little kids that they can demonstrate impulse control. But the marshmallow test is something everybody identifies with. But if a child, by validated metrics, can demonstrate good impulse control, good self-control, and that goes with good sleep. You all know that. Everybody here, if you know Simon, you know the importance of sleep and breathing. Well, these kids, that's one of the metrics we use to see if their sleep is getting better when we start to develop their jaws and their airways. And that is something that absolutely can predict, and this is from the Dunedin study, their biological rate of aging. Now, what is biological rate or pace of aging? If you imagine a car, there's a odometer and a speedometer, okay? The odometer is your chronological age. That's how many miles your car has gone. That's how many seconds, minutes, hours, months, years that you've lived. That's your chronological age. Your speedometer is the rate at which you're aging, and it's modifiable. And you can help a child have a very slow rate of aging. This Dunedin study showed that these kids, born in 1973, by age 12, They had good impulse control. By the time, before they were 40 years old, they looked 10 years younger. They had less criminal behavior, less addictive behavior. They managed wealth better, and they had less chronic disease. They're predicted, and this was back in 2001, these kids are probably going to have a greater lifespan. Well, now 20 years later in 2021, guess what they found out? They've determined biological rate of aging, pace of aging. Have you heard of telomerase, telomere length? They're the DNA at the end of your chromosomes. They shorten under something called oxidative stress. Okay, and they don't reach their limit of ability to mitotically divide. That's something called the Hayflick limit. All your mitotic cells have a capability of dividing about 60 plus times. But if they start dividing too fast, the telomeres get short, the body, the immune system, thinks it's cancer. So they arrest it. That's what uncontrolled dividing of cells is. They're immortal cells. They don't want cells to become immortal. So they interrupt them and they become senescent. That's senile. That's the term. And it accumulates. And they don't die. That's not cell death. They stay around. And if the immune system doesn't clean them up pretty fast, they start secreting things like interleukin 6 and C-reactive protein, really bad things. Well, in early life, they don't really cause noticeable problems, but they start to accumulate. So now I'm going to jump to something really quickly. And I don't want to lose anybody here. And, this will be recorded. I sent Simon a lot of papers that support this hypothesis. Do you know, and Simon, I'm not sure I've asked you this or posed this question to you, but any child born with Down syndrome, okay, trisomy 21, do you know what between the ages of 35 and 40, what 100% of them will be diagnosable with? Alzheimer's disease. Alzheimer's disease.
Yep.
And the best explanation for that is that I talked about amyloid beta. Those are the plaques that form around the synapses in the brain. Okay. Amyloid precursor protein. All right. The locus. Guess which chromosome the locus resides on? Number 21. Okay. They have 3 versions of making amyloid beta protein, amyloid precursor protein. So these kids are producing amyloid plaques that is initiated or catalyzed by oxidative stress. Most of them have malocclusion, right? They don't breathe and sleep well. That induces oxidative stress. Oxidative stress just means you have an imbalance between reactive oxygen species, free radical generation, and antioxidants. You're not eating enough exogenous, dietary antioxidants, and your body has endogenous antioxidants that get replenished by dietary antioxidants. That's why it's important these kids start eating closer to a Mediterranean diet. The ultra-processed foods that require no chewing, they put on weight. They have salt, sugar, and fat. When they don't have a healthy body weight. That induces oxidative stress. That is going to prevent cells from dividing, getting arrested, turning into senescent cells, and these beta amyloid plaques start to accumulate from a very young age in Down syndrome kids. All of them by 40 years old will have Alzheimer's disease. They used to not live that long. So this has been a recent discovery. So now amyloid plaque in the brain is necessary, but not sufficient for a diagnosis of Alzheimer's disease. There's something else that the amyloid plaques are extracellular. They surround the synapses in the brain, the neurons, and when they accumulate to a certain amount, your microglia, you've all heard of glymphatics maybe, when you're in stage 3 slow wave sleep. That's when your brain cleanses and clears out amyloid plaque. Okay, if a kid's not getting stage 3 sleep, whether they have Down syndrome or whether they're kids that are non-syndromatic, they're not going to clean up these plaques and they're going to accumulate even in healthy kids. Okay, well, accumulation of beta amyloid is, again, necessary but not sufficient for diagnosis of Alzheimer's. There's something else called phosphorylated tau. They're tangles. They're intracellular tangles. They're proteins that are inside the neuron. So again, necessary but not sufficient to cause Alzheimer's dementia. It's still Alzheimer's. It's diagnosed as Alzheimer's disease, but there isn't always dementia. So now you have extracellular plaques around the synapses. You have the microglia trying to clean it up, and there's so much there that the microglia, they're hungry. They're called the janitors of the brain. Well, they start chomping up all this amyloid, but there's so much of it that they're actually cutting into synapses. Okay, inside the neuron is tau protein tangles. Okay, so now you've got two things that are both necessary but not sufficient. Do you know what tips it over, Simon? And this is really important for everyone to know. And there's again another paper I'll send you about 90-year-old nuns in a convent that had all kinds of beta amyloid in their brains after they died. They did biopsies. They had internal tangles in their neurons. None of them had dementia. Do you know why? No inflammation. Okay, it's inflammation that turns intracellular tau, extracellular beta amyloid. Inflammation is what turns it into dementia. And there's different types of dementia, and it can happen at young ages. But this is something that we are hypothesizing, is that if we can get these kids early in life to sleep and breathe well, to have a healthy weight, to get adequate sunshine, to be outdoors, to be breathing clean air while they're awake and asleep, to be social, to be learning, to be in school, not only just being in a good school, but having the ability to pay attention. We think this is setting children up to not only have a greater lifespan, but to avoid age-related diseases, neurodegenerative diseases like Parkinson's, like Alzheimer's. So, and we're putting this to the test. We're writing an IRB proposal for funding, and we're getting a lot of attention paid to this. That's all I can really talk about right now, but I couldn't wait to share it on this forum, Simon, and this is what I want to talk about in November.
Fantastic. So from what I gather, if I could summarize in plain language, is genetically we're all predisposed to aging. But how miserable our life becomes depends on how much inflammation there is in sometimes early childhood life. Inflammation, oxidative stresses are most commonly triggered, certainly from our clinical perspective as dentists, with oxygenation issues at night, sleep deprivation issues at night, and dietary intake that may or may not trigger all the chronic inflammatory stresses in the system. Our cells are designed to have a cycle of cradle to the grave, but these additional unnecessary oxidative stresses can upset the wound healing and the growth and development processes and create that kind of zombie type of cells that are very detrimental to all aspects of our life. In particular, what you've talked about is how it affects the cognitive development in older years. And it's interesting that you mentioned that as we age, we all build up the plaques, but whether those plaques manifest as Alzheimer's is very much environmentally related. And I think
Bingo.
this is
That's the most important point, what
Yeah,
you just said.
environmentally reclaimed. So how do we kind of take this motivation, like we're all motivated to help children have better lives. It's a innate emotional drive. It's like our prime directive, isn't it? To be fruitful and multiply and leave the genetic legacy of our lives onwards. So as dentists, as primary care physicians in dentistry, my focus is on developing good balance in jaws so that function, aesthetics, mastication, airway management, alignment for optimum biomechanics. That's part of postural orthodontics. What focus should we as primary care dental physicians be most observant of? A lot of things we can't treat, but we should be able to screen for the various different specialists.
Well, the first thing is, it's like that seminar that I was at, and the speaker said, how many people here are over 40? And really, probably you have a mature audience, okay? And you know what? If you're almost 40, you're 40, you're already making these plaques, okay? And at what rate are you making them? So think about yourself for a minute, and are you overweight? Are you eating mostly a Mediterranean diet? Who does that? Your alcohol consumption. Do you smoke? Are you around it? Think about yourselves. What do you want to do with the rest of your life? Okay. Like, do you want to slow down? And have you heard of pace of aging, rate of aging, biological aging? This is a reality. Rate of aging is a phenotype that is modifiable from birth, actually. So I think you don't, and how many people here are treating kids under 6 years old? I don't know if you are, but really helping optimize. What I say is my goal in life, what fulfills me is optimizing a child's structural and functional ability to habitually nose breathe while they're awake and asleep at the earliest age is feasible. Well, if a child moves from Sydney to America and comes to Chicago and they're 12 years old, guess what? That's the earliest feasible age I can treat them. But kids locally in Chicago and surrounding states, and I'm a pediatric specialist, and we like to see kids before age 1, and not just looking for cavities like I used to, but looking for antecedents to malocclusion, because malocclusion at any age means that there is a myofunctional disorder. So first of all, you want to identify those, and you need to begin to optimize the structure and function. So I really, it's kind of tough to, because the environment is, most people conventionally trained in orthodontics, why would you treat a 5-year-old without a crossbite? In fact, Dr. Boyd is unethical. Nobody should do that. So they're not only, saying that there's not a problem there, and often somebody maybe meaning well that just really doesn't know what they don't know. They'll say, "Oh, your kid is still growing." Well, what they mean is the long bones are growing, but above the neck, this craniofacial complex doesn't grow like long bones. They have to be grown, like the cranium has to be grown by the brain. The lower underneath the cranial base, that has to be grown by mastication, by myofunction, by assistance from expanders and orthopedic corrector, things like that. So this is what, the lay public doesn't know, because the orthodontic conventionally trained orthodontist or primary care dentists or pediatric dentists that have been influenced by a conventional approach. Oh no, let's wait till there's more permanent teeth. And Simon, I got this analogy from you about 15 years ago. What about a child who's got myopia at 4 years old? Would you ever say, look, you don't want to have to go through 6 different you called them spectacles. I said 6 different pair of glasses here. If your kid is nearsighted at 4, they're probably going to need at least 4 or 5 different pair of glasses before they're driving a car. That doesn't mean you shouldn't treat them now, even though they're going to need more later. And the analogy is a good one. It's a medically defensible analogy. And Simon, I got that from you several years ago, and it's really helped a lot of parents understand. No ophthalmologist, no pediatrician would say to the parents of a 4-year-old, sorry about your kid's nearsightedness. They're going to have problems because they can't see the board, and they're compensate. They don't know what's normal vision. But let's wait till they're like 14. You'll save a bunch of money by just doing one phase of glasses. And I urge people to think about that. And if you really want to help a little kid who's got a deep, narrow palate, a V-shaped arch, a retrognathic mandible, a large overjet, circles under the eyes, wets the bed after potty training years, tosses and turns, sweats, drools, has night terrors, you don't have to sit by and watch that. And if somebody who's conventionally trained in orthodontics who says you shouldn't be doing that and convinces parents they should wait, I think that is a form of medical neglect. It's professional neglect. You know what? If I get a little frustrated, I always remind myself I haven't always been this way. In fact, Simon and I started to get this way together when we started taking orthotropics courses from John Mew and Bill Hang. And now we know we're helping lots of kids. And the tide is changing. The American Dental Association has policy statements now to at least assess risk, if not treat. And if you don't want to treat, don't know how to treat, until you get yourself educated in doing this, find somebody like Simon. Find somebody in your community that will do this, because there's more and more people, more and more primary care dentists. It isn't just pediatric dentists, orthodontists. It's mostly general dentists, people who graduate from dental school who absolutely, I really think that it's the general dentists, we call them primary care general dentists. They're the ones who are going to save the world here. Orthodontists are too busy straightening teenagers' teeth, and pediatric dentists were inundated with tooth decay. We're putting out sugar fires all day long. So I don't know. This is a great forum you have here, and I hope I get some people curious. Give anybody my email, Simon. I'll send them pictures. I'll send them papers. I'll talk to anybody who wants to be talked to about this.
I think it's very difficult to grasp the extent that we can influence growth and development. Like we live through life, we have this mental view of what things can be affected environmentally, what things are genetically rigid, and we give up too early when it's a difficult change. And I think that's the biggest roadblock, whether it's at the academic level, whether it's at the professional level, or whether it's at the family level or the individual level. We're happy to try stuff when it's easy, but we're reticent to work hard to make change when it's so easy just to blame it on genetics, right? We say, look, I tried, I couldn't change it, so I must have been born that way. And I think that's the biggest roadblock to change the course of our life. It is very easy in early childhood to see how big an influence the environment has. That's why we're so protective against infants and young children. But once we leave that toddler phase, we tend to relax our guard and just accept whatever happens as destiny, so to speak. And when we have the long view, which is what you're talking about, right? How does geriatric medicine impact early childhood? And we have the long view when we're, there was an old-fashioned dental phrase called looking after someone from cradle to the grave.
Mm-hmm.
And
Womb,
the
womb
reality,
to the tomb. We say from the
yeah,
womb to the tomb.
very good. In Australia, it's called cradle to the grave.
Mm-hmm.
It's a concept that only makes sense when you have gray in your hair and have been practicing for decades. Because not only do you have the patients that you've been looking after, but then you start looking after their children. And then in a blink, you're looking after their children. So you're seeing 3, sometimes 4 generations. And then that concept of, womb to the tomb and cradle to the grave makes sense. And you realize the decisions that have been made for those children manifest very differently in their adulthood when you've been looking after them for those many, many decades. I think it's very important that we respect the wisdom that history has shown us, and we don't look back far enough. One of the things that has been criticism that I've had in academia is discounting research papers that are more than 10 years old. And one of the things that I always remembered you doing was looking back at dental research and orthodontic research from the early 1900s and always citing the early research, and then, being stonewalled by so many in our profession who says, well, why would you look at anything over 10 years old? And that's just completely discounting the wisdom of experience that is present if we make the effort to look back at the cycles of life.
Well, you never hear people criticize Einstein came up with E equals MC squared 130 years ago. I mean, that's old research. It's like, okay, how about electricity? How about a cure for cholera? I just, there's so many old scientific, vitamin C, that's pretty good for scurvy in the 1700s. Not too bad, huh? Oh, that's old research. We shouldn't take vitamin C. So, no, that's a good point, Simon. I
Basic
love old
science,
research.
human physiology, human biology, the basic sciences have to be remembered. We're taught this in our undergraduate training, and then we promptly give it all back to teacher after we graduate. And it's a shame because all the work that you're looking at now with cell replication, cell senescence, the reproduction of growth and development and change in, the genetic makeup and how the environment affects it. This has an immense impact on our understanding of how much the environment can affect growth and development.
Mm-hmm.
It's too lazy of us to say, well, we can't change a child's growth and development in their bone structure because I tried and it didn't work. Like that's not an excuse. That's like you tried and failed, so it doesn't mean that someone else can't do better.
Yeah, it didn't work in your hands. That doesn't
Yeah,
mean it can't be done. And
exactly.
I've heard that one too. I just like, oh, well, we got our work cut out for us, Simon, and it's great work. It's noble work. I feel so useful to society, and to get up every morning and just on my way to work, I'm going to be 71 in February. I have never enjoyed being a pediatric dentist like I have in the last 15 years. And it's just so you get direct, it happens so quickly in some of these little kids. And when your staff, dentalists, they're hearing the parents, oh my God, they're doing better in school. And he just, life is better. He's not getting sick. ADD's clearing up. He's off of Ritalin. And your staff is hearing that. The energy in my office. Simon, I would love to have you just come up and watch what's happening here. And, we had a group from Boulder, Colorado on Monday. It's a big medical dental network that they want to integrate pediatrics into their mainly adult sleep and airway medical dental. They have 5 clinics. They're expanding to 7 or 8, and they want me to become the pediatric dental director. But I wanted them to come and see what was happening and see what they were getting. And they're all in. So I'm going to help develop this, and I'm going to try to maybe get you to be part of this and maybe have you come in and guest lecture, Simon. It's a big deal. It's a really big deal. I get to do research. So I'll tell you more. This just happened on Monday. So
I've
big
got
deal.
a question that might be of value for our group. One of the big problems that we have in Australia is medical and dental professionals are very cognitive of the fact that a poor diet will have a huge detrimental effect on childhood development. But the problem
You're frozen.
Yep, I think Simon is temporarily frozen. While he's
Yeah.
probably rejoining in a minute. Thank you, Kevin, for sharing those 8 articles. I just put it in the chat. For those of you who want to learn more about the geriatric medicine and pediatric dentistry, check out the Google Drive. I uploaded all 8 articles that Dr. Boyd kindly shared with me today. So feel free to download that. Simon, you're back. I know, Kevin, you only originally were, we've definitely gone over time, and thank you for staying this extra few minutes. Do you want to wrap up, Simon, or open the Q&A for some folks? If Kevin, you can spare another 5 minutes, or if you got to run, I know you've already.
I can last not quite 10 minutes.
Okay,
It's a
true. We're
little
going to
more
wrap
than
up in
5.
about
Yeah,
7 minutes, and Simon has to wrap up as
yeah.
well in about 7 minutes to get back to work. But
Okay.
so just 2 things. One, we've got the Google Drive for the 8 articles. We'll email it to everyone and the recordings of tonight if you join a little bit late. Secondly, if you'd like to join both Kevin and Simon, we have our 2-day program, our formal 2-day program on early interceptive postural orthodontics. Kevin will be presenting formally for about 90 minutes. And the bulk of it will be Simon on postural orthodontics. It's November 7th and 8th, Friday, Saturday, starting around 2:30 p.m. Eastern. It's 7 hours both days. The link is in the chat area. Early bird specials end next Wednesday, so plenty of time to take a look at that. Thanks again, Kevin. But I will open up to questions. So if you've got a question, if you want to raise your hand, if you want to join us on the panel, or just type any questions you might have for Kevin. But let's see if anyone has any questions for you both. But while we're doing that, Simon, you want to?
yes, there was one question from Dr. Pilar. You talked about diet. What types of food, snacks, etc., are you recommending to your pediatric patients and families? What can we do for the young kids to help with their growth and development?
The first thing I would say, and this is actually a form of myofunctional therapy. Does your child chew their vegetables or do they suck them out of a pouch? Okay. And the masticatory competence, that's the texture of food, is what's left out of the equation. You can get all the vitamins and minerals and trace elements and phytochemicals, but if you don't have to chew it, you're not going to develop the masticatory complex, which is connected to the respiratory complex. So that is my first thing, is try ultra-processed food, UPFs, okay? There's a book that I highly recommend. It's called Ultra-Processed People, and it's by a pediatrician from England named Chris Van Tulliken. So that is a great book that will, and he actually brings up is that applesauce, there's been experiments done that shows, do you press all of the fiber out and make applesauce or apple juice, or does you use your teeth to dismantle the apple and chew it? Okay, this is a pediatrician who I recorded that when I heard him speak. So that is something that you can do. It's broad based. You don't have to have a master's in nutrition and dietetics to give that advice. Ultra processed food is too soft. Okay, but you don't take it away completely. It's almost impossible to do in this day and age. If your kid wants to eat Vegemite, right? Isn't that what isn't that's kind of soft? And well, make them eat an apple and chew on some carrots and celery too. If they want macaroni and cheese, go ahead, but you got to add some carrots and broccoli, and they have to chew. Soft food, nobody has to chew anymore. And I think that's a big part of the problem. These kids, even if they're not overweight, they're just not getting adequate nutrition. They're not biologically processing food. So that's my advice. That's what I give.
Okay.
There's
Yeah,
another
I think
question.
it's very important. Next question is, Dr. Simon always says we have to give liquid to 6 months, then solid, then semi-solid. But 6-month-old don't have teeth. How will they eat solid food? Having two kids asking this as a mother. Like the timeline varies from child to child, but the natural progression of our development is liquids, solid, and semi-solid, in that order. We tend to break that by going from liquids to semi-solids at 6 months. So what it basically says is, where did the semi-solids come from? And the answer is semi-solids come from processed foods, which is what Kevin talked about.
Yeah, I don't like Gerber. I think Gerber baby food is the worst thing that happened to us.
Yeah.
They were first advertised as for infants and invalids. Okay, it's all wrong. The anthropology says no, children need to be able to chew what every hunter-gatherer in the tribe was chewing by 12 months of age. It's called baby-led weaning. And, Joe Rapley is a friend of mine, anthropologist. Look up baby-led weaning, cup feeding. These are things, artificial nipples and bottles and formula, not good. If a woman isn't lactating and she can't breastfeed, then it'd be great to get, if there's a human milk bank, I don't know what that's like in Australia, but human milk for human babies. Infant formulas are based on cow's milk. They have no oligosaccharides. They do not feed the microbiome of the lower GI tract. It's bad. It's not good for building the immune system. Human milk for human babies, pumped or preferably out of the breast. Getting on, as long as a kid can sit up, then that kid can hold on to a pork chop at 7, 8 months old and gnaw at it. They can eat an avocado with their hands. They can chew things, gradually get harder. But that's what we're wired for genomically. And this is my anthropology background. If kids couldn't eat everything that an adult was eating in the tribe of hunter-gatherers, by 12 to 14 months of age, they died. And you don't see any malocclusion in the fossil record. At any age, a child would not live long enough to develop a malocclusion if they couldn't nurse and wean according to an ancestral pattern. I won't, that's a hypothesis, but very plausible. And I've been given a thumbs up by several anthropologists who think there's something to that. So why do we not
I
find
think
malocclusion?
nature has supplied us with breasts, teeth, and hands. right? So if you go to a farm, have a look to see how many spoon trees there are in the plantation. And when you find the stainless steel spoon tree plant, then take a picture of it because I'd like to see it.
Hmm.
Right? So spoon feeding is the enemy.
Use your
All right.
hand. Let babies use their hands. I just like.
Let them use their hand. They'll figure
Yeah.
it out. They'll figure it out.
Simon, I gotta go now.
Excellent. Yes, I was just about to say that. Thank
I've
you so
enjoyed
much.
it. I've enjoyed this immensely. If I was a cat, I'd be purring right now. So,
All right.
thanks
Thank
for
you so
having.
much, Kevin.
All
Thank
right.
you,
Well,
Kevin.
All right. Thank you,
talk,
Simon. I know
guys.
you're going to go as well. Thank you, everyone, for joining
Yeah.
us tonight. Until we meet
So,
again.
Good deal.
Ken will wrap things up and explain to you the
Oh, yes.
November 2-day introduction. So hopefully I'll get to see you guys there.
Terrific. Thank you, Simon.
Bye-bye.
All right. Thank you, everyone. Just to wrap up, if you're still with us, once again, November 7th and 8th. I will share my screen briefly. I'll just share the link. Thank you, Sony. Thank you, Carol. Thank you, Lauren, for your kind words. 7th and 8th. It's our 2-day 7th. We do this normally once a year. We're going to do another one end of this year, November 7th and 8th, from the comfort of your home, a live stream via Zoom. Kevin will be joining us live on day 2. We had actually Amanda Wilson and Professor Narinder Singh join us last year at our last year's event, which we held at the Hilton in New Jersey. It was an in-person event, and we'll include the full recordings of that 2-day program. Also, it's a similar core training, but we had different guest speakers. So we will include the full recordings of that 2-day with the purchase of a ticket. So you don't have to wait till November. If hypothetically you wanted to do a bit of a warm up and watch the entire program from last year, which we held at the hotel, that's a free bonus during this early bird kind of phase, which will end in about 7 days, mid-October. And it's a full 2-day. We've got deep discounts for allied health professionals, for whether you're a myofunctional therapist or RDH or a dental hygienist. You'll learn all about how to implement the lower Wong widget and the upper. These are both removable expansion devices that my brother developed, inspired by the Schwartz appliance for the lower and based off Professor Mew, the late and great Professor John Mew's BioBlock for the upper. And then when you combine that with GoPex, good oral posture exercises, it's the trilogy, the trifecta to get the results that Simon's been getting for many decades and has been teaching dentists all around the world with his particular method. Kevin will be joining day 2. I think it's going to be a 90-minute presentation. We forgot to update that. You get the recordings, instant recordings of Amanda's presentation. She's an orthodontist out of Hawaii. Professor Narinder Singh, ENT surgeon from Sydney, Australia. Once again, it starts at 2:30 Eastern and ends around 10 p.m. Eastern. So for those of you in the US, please, obviously if you're from West Coast, it'll be 11:30 a.m. until 7 p.m. Pacific. If you're from around the world, just use World Time Buddy to figure out the if you're in Australia, although Simon's based, it's 6:30 a.m. start on Saturday and Sunday, and it goes about 7.5 hours both days. What's included? Well, we're going to give you the recordings of last year's event straight away, and we'll include the recordings of the event itself if you can't make the entire 2 days in its entirety. Plus, importantly, over 500 pages of detailed practice templates and protocols. Some of you have gotten our 7-hour mini course. That is essentially of day 1 of one of our 2-day programs back a few years ago. Obviously, we're not including the secret sauce of all this IP that is very detailed notes and practice templates and whatnot. That's only if you join our formal 2-day program, of course. So we've got some specials at the moment for another week. Regular price $997, live stream is $697 only. If you just want the recordings of last year's event and this year's event, and don't, if the time zone is such that you know attending the live stream, it just doesn't make any sense, then just get the recordings only option for $597. So it does come with a certificate of completion. There's a CE test as well, and a 30-day money-back guarantee. So you can check out the full recordings from last year's event, decide if it's for you or not before we actually have the live stream on the 7th and 8th. About, well, 30 days time. That's about it. So do join our early interceptive postural orthodontics movement and check out all the free resources that Dr. Boyd shared, the Google Drive. Check out Ultra Process People. That sounds like an interesting book. And baby-led weaning. On that note, does anyone get any questions? Otherwise, we'll wrap up. It's late Wednesday evening here in New York. Thank you, Dr. K. Thank you, Dr. Verma, for your questions, and Dr. Buller. Yes, we're recording this and we'll upload it by tomorrow, and we'll send the link and all the research papers in the email as well. So if you missed part of the presentation, not to worry, we'll send you the recordings. Alrighty. All right, thank you, Candace. We'll say good night to everyone. Thank you, Alta. Thank you, Raina, Arias. Thank you. Good night. Thank you, good night, John, Carol. We had about 50-odd people tonight, which is nice. And it's time to, it's not too late for you guys in the West Coast. Thank you, Dr. Ling from Malaysia. It's good to have a fellow Malaysian join us. Good night. We'll wrap it up. Thank you. Take care. Bye-bye.